So good afternoon and good morning to those joining us on the West Coast. I want to thank and welcome all the attendees for joining in this webinar. My name is Shawn Deane. I'm General Counsel here at Ametros. We're really excited to present this webinar today where we're going to provide an update on all things Medicare Secondary Payer and professional administration. I'm excited to be presenting alongside Sid Wong. Sid's one of the most foremost industry experts and happens to be a longtime friend and colleague of mine. Sid's Vice President of Policy at ISO Claims Partners. And ISO Claims Partners is an industry-leading full-service Medicare Secondary Payer compliance provider where Sid's been for over a decade now. And today, Sid will be covering an update on Medicare Set Asides and conditional payments and Section 111 reporting. And I'll be covering an overview and updates on professional administration, as well as sort of how professional administration can assist with overcoming certain barriers. As a matter of housekeeping, if any of the attendees has an issue in accessing the webinar or experiences a technical difficulty, we're joined by Melanie and Melissa at Ametros who can assist you via the chat function if you experience any issues there. And during the presentation, should you have any questions, you can feel free to submit them through the chat box as well. If there's time remaining, we'll try and get through as many questions as we can. However, if we're unable to address a specific question, we'll be sure to get back with you directly. We have a lot to cover. And as you can see, we're going to go through Medicare Secondary Payer. Sid's going to hit that, go over an overview and some updates around Section 111 mandatory insurer reporting, conditional payment recovery, and MSAs, and then I'll take professional administration. So without further ado, I'm going to turn it over to my colleague and good friend, Sidney Wong.
Thanks, Shawn. Good afternoon, everyone. It's really excited to be here today to present with Shawn. Medicare Secondary Payer has a lot going on. So the way that we decided to break it down is to kind of give you an overall high-level overview of Medicare and the various Medicare compliance components, and then kind of update, with what's been recently going on to give a more, a fresher look at some of the more prevailing issues. So, generally speaking, we can talk about any one of these sections for an hour or more. So, I think that this is a good way to approach this, but certainly let us know if there's any additional questions after this, and we're happy to cover them as Shawn has indicated. So starting off, let's talk about Medicare generally. Medicare enrollment, as I'm sure that most of you folks probably know, it's a health insurance program, and it's administered by the federal government. And this federal insurance program is primarily designed for or provided for a certain subset of individuals. When we look at individuals that are 65 years or older, so if a person is 65 years or older and have paid long enough into the Medicare system, they're generally eligible for Medicare benefits once they attain that age. You're not dealing with somebody that's 65 years or older, but is an individual that has been awarded Social Security Disability or SSDI, and this is distinguished from SSI, which is Supplemental Security Income, which is different because it doesn't have a pathway to Medicare, but SSDI does. And if an individual is on SSDI for 24 months or more, they are also eligible for Medicare and automatically enrolled in Part A. If you're not dealing with either somebody that's 65 years old or is receiving SSDI, an individual might still qualify for Medicare if they have a qualifying condition such as end-stage renal disease or ALS. End-stage renal disease would be a situation where there's kidney failure and the individual requires either a kidney transplant or regular dialysis. That would be a circumstance which would also qualify an individual for Medicare benefits as well. So if a person does qualify for Medicare, they have four main parts that are available to them. Part A, which is inpatient hospitalization. Part B, which is outpatient services. That's what we consider as traditional Medicare, and that's been on the books, been around since 1965. And as part of traditional Medicare, individuals don't get prescription coverage automatically. If an individual wants prescription coverage as well, they typically turn to and select a Part D plan, which has been around since 2006. And they would pay an extra premium for that. They would select a plan and they would get medication coverage through that Part D plan. Alternatively, there's also Medicare Part C, or Medicare Advantage, Medicare Plus, Medicare Choice, all falls under those titles. But that's considered Medicare provided by a private insurance company. So that would be something like Blue Cross Blue Shield, Humana, Kaiser. They all have a Medicare Advantage plan available, and typically they provide more flexibility and more and greater coverage than traditional Medicare. Typically, they have to provide at least what traditional Medicare provides, and often provides more. As part of Part C plans, we often see medication coverage as part of those as well. So if an individual qualifies for Medicare, they can select these different parts as part of their coverage. Now, you can't have both traditional Medicare and Medicare Advantage. You either have to select one or the other. The other thing I wanted to point out, because I often get questions about it, is the differences between Medicare and Medicaid. And really, to distill it down, is Medicare is a federal insurance program administered by the federal government, outside of the Part C plans. Medicaid is really administered by the various states, and it's a means-based benefit. So it would be based off of the level of income an individual would make, and if they make under a certain level of income, then they might qualify for Medicaid as a result. All right, let's take a look at the next slide and see where Medicare Secondary Payer fits in. So we talked about Medicare. What's Medicare Secondary Payer? Where does it fit in? Well, Medicare Secondary Payer, or MSP for short, is based off of a federal statute, regulations, policy manuals, and emerging case law. So you have to turn to a couple resources to really paint a full picture. But if you wanted to look at the main points of it, it's really to identify and dictate situations where Medicare is secondary and what happens when Medicare is secondary. And in most cases, most coverage plans are secondary to Medicare. In fact, I would say Medicaid would be the only plan off the top of my head that would be secondary to Medicare itself, because Medicaid is a payer of last resort. But for the most part, if we're talking about workers' compensation, liability, no-fault claims, those are all considered primary payers to Medicare. And notably, self-insured municipalities are also considered primary payers under the MSP statutes as well. Now, the crux of this is and the purpose of MSP is, one, to coordinate benefits and to identify when Medicare is secondary and utilize that to protect and guard the integrity of the Medicare Trust Fund. Some of you guys might know that the latest talk was that the Medicare Trust Fund is likely to be insolvent by 2026, primarily focused on the funding for Part A. But that's something that is really concerning for, obviously, Medicare beneficiaries, individuals that will become Medicare beneficiaries, the federal government. So there's a huge interest to ensure that the trust fund maintains that solvency as long as it can. How that is broken down and how that coordination of benefits is broken down as far as compliance elements is into three main components. One is the mandatory reporting requirement under Section 111 reporting for responsible reporting entities, or RREs. The other is the recovery of conditional payments. And then finally, future medical consideration post-settlement through Medicare Set Asides, which I'll all talk about in the subsequent slides. Let's take a look at the next one. So as far as Medicare and the updates, I do want to start with just kind of briefly talking about the contractors. And I think a lot of people, when they think about CMS, they think about, which stands for the Centers for Medicare and Medicaid Services, the federal agency. What's important to know too is that CMS actually utilizes a number of contractors to assist with coordination of benefits and to assist with processing MSP related matters. So for Section 111 reporting, that's the Benefits Coordination Recovery Center, or the BCRC. And for conditional payment recovery, it also involves the BCRC, but also involves the CRC as well, which is the Commercial Repayment Center. And that's primarily split between the handling of liability type claims with the BCRC and the handling of no-fault and work comp claims for the CRC. There's a subtlety to it too, depending on when TPOC evolves, but just that's probably the most simplistic way of kind of breaking down, which contractor handles which type of claims. On the work comp Medicare Set Aside end, or the WCMSA side of things, it's the process is handled by the WCRC, or the Workers' Compensation Recovery Contractor. And one of the questions that we've recently received on our end, as far as ISO claims partners is concerned, is with the spread of the COVID-19 global pandemic, how will that affect, or will that affect MSP related situations and CMS's ability and CMS's contractors' abilities to process claims. So the information we've gotten back from CMS, and to be honest with you, CMS has been very responsive about this, been very forthcoming with respect to that, and have indicated that contractors, the BCRC, WCRC, and CRC have all transitioned to working remotely in the wake of COVID-19, and CMS continues to monitor the service performance of its contractors. If there's any suspicion or situation where they feel that significant issues would arise, they indicated that they would post an alert on the cms.gov website. So if there's something that posts up there that would signal that, we would probably want to take a closer look at what's going on and strategize around that. To date, we can confirm that we haven't seen any interruption in services, any delays in getting back MSA determinations or conditional recovery disputes and information, and we'll continue to monitor that situation, as well as the mail capabilities for conditional payments. So as far as Section 111 reporting is concerned and MSAs, those are largely handled through the electronic, through electronic means. The submission of WCMSAs through the workers' compensation Medicare Set Aside portal, remains electronic. So that really hasn't really seen any impact. One thing we do concern ourselves about, though, is that even though conditional payment recovery does have the MSPRP portal to utilize to assist with the dispute analysis and obtaining of conditional payment information, it still largely relies on manual mail processes. So we're monitoring mail processes through the United States Post Office, as well as the contractor and CMS's ability to process manual mail as well. So just wanted to keep an eye on that, and if there's anything that changes, we'll certainly want to kind of raise that and see if there's any consideration for the due dates and turnaround times that are associated with conditional payment recovery. But so far, so good. Turning to Section 111, the basics and kind of outlining what they are. Section 111 was implemented back in 2007, and the intent was to assist with coordination of benefits, right? So, Medicare has been on the books since 1965. Medicare Secondary Payer recovery has been on the books since 1980, and during that time, before Section 111 was enacted, Medicare largely relied on self-reporting, right? So if a claim settled, that the insurance carriers or the beneficiary or the representative would call up Medicare and say, hey, by the way, we settled the claim, it involves a Medicare beneficiary. Can you please let us know if we owe you anything? So largely not very efficient. And so Medicare implemented this reporting requirement to make it easier for Medicare to identify situations involving a Medicare beneficiary, putting the requirement on these insurance companies, on the responsible reporting entities to provide this information and really streamline the coordination of benefits component of recovery. And in the context of which we look at it and we discuss it for non-group health claims, we've discussed it in the past, right? Primary payers would be considered liability claims, work comp claims, and no-fault claims. And in order to effectuate compliance, Medicare implemented originally a penalty of $1,000 a day per claim for non-compliance. They later kind of eased that up a little bit, amended the language through the SMART Act to say that they can impose civil money penalties of up to $1,000 a day per claim. And to date, they haven't imposed a civil money penalty yet, but a lot of the talk this year has been Medicare's finally releasing the language around the proposed rules for civil money penalties. So we'll talk about that in a second. But the last point I wanted to make is how critical it is that the data and the accuracy of the data that's being reported to Medicare largely affects their conditional payment recovery process. So there's a huge tie in there. I think a lot of people like to consider Section 111 reporting as a separate and kind of isolated requirement than conditional payment recovery, but really there's a huge link there. So if ICD codes are not reported properly or information is not reported timely, that can affect how Medicare recovers and what Medicare tries to recover on the conditional payments side. Let's take a look at what the civil money penalties are and where we are with them. So back in February 14th of this year, Medicare finally released, after about a year and a few months or so of kind of teasing that they were going to release proposed rules around this. It was initially announced back in December of 2018, kind of gotten little bits of updates throughout 2019, and finally got some the release of it in February of 2020 this year. So I'm going to go through it. Let's go clockwise, starting from failure to report and kind of talking about that. But basically, Medicare, to kind of just sum it up in a nutshell, had looked at three main areas where they would be looking to impose civil money penalties for non-compliance of Section 111 reporting. So failure to report the first one. So if there were claims that were required to be reported because you're dealing with a Medicare beneficiary, because there was reportable events, and it's not reported, and Medicare is able to identify that, and it's shown that it should have been reported, but it hasn't been reported in 1 year, then Medicare can impose $1,000 a day penalty for each of those days of non-compliance for that one particular claim. So I think that that's not really a surprise. I think that failure to report is one of those things that I think it's fairly obvious that Medicare would try to target. I think some of the questions that we might have is how Medicare would identify failure to report, things around that, and we'll certainly see what Medicare says after the comment period is through, and they have an opportunity to kind of review some of the questions and issues that the industry raises and be able to address them in a response. So failure to report. The other one that was a bit of a surprise and is kind of interesting is Medicare also indicated as part of these rules that they would look to situations where a conditional payment dispute contradicts Section 111 reporting data. So in the prior slide, I mentioned how important it was to make sure that that data is accurate. Well, Medicare's taking it a step further and saying, hey, if you are trying to dispute something, and let's say you reported ongoing responsibly for medicals, and now you're trying to report that no, in fact, the claim is denied, we never had ongoing responsibility, and your dispute is based off of that and it conflicts with the Section 111 reporting data, Medicare could tag you for civil money penalties for that inaccurate reporting. So then you would have to kind of determine and juggle, do I eat the civil money penalty or do I eat the conditional payment recovery amount? And we have our comments around that, but that's another consideration that Medicare is looking at. And then finally, Medicare is looking at reported data that exceeds the established error tolerances 4 out of the 8 consecutive reporting periods, which right now is 20%. So where 4 out of the 8 reporting quarters, Medicare identifies that the claims are over that threshold, they would actually treat that reporting the claims reporting during that period is all in non-compliance. So that, again, an interesting way of approaching that. We have our comments around that, specifically around the fact that even though 20% of those might have fallen under threshold, that implies that the remaining amount was reported properly. So as a result, it's inequitable to be imposing civil money penalties on claims that were properly reported. You can argue that the ones that were improperly reported might be subject to it, but having the ones that were properly reported, would be inequitable. So a couple of things, just to kind of walk through this a little bit further and to flesh out a couple other things within this. There was a comment period that just closed yesterday at 5 o'clock. So that was the industry's opportunity to provide comments and feedback around those. Medicare did also did add language to the proposed rules around good faith efforts in situations, especially liability claims, where it's difficult to get information to report for Medicare, especially for the query process, like Social Security number or date of birth. So there are instances where an RRE could show good faith by contacting the individual, explaining why you're you're asking for specific information, what type of compliance it's for, and following up a few times in either fax or email as well, and documenting the file to show that good faith efforts were made. So there was some language around that to provide some relief for areas that you can't obtain that information. Also, these rules were considered to be prospective, which means that Medicare is only looking to apply these after the rules are implemented, if and when that might occur. And then as far as next steps are concerned, Medicare, will be reviewing the comments, and they can either choose to roll out the rules without any changes, make some changes and implement another commentary period, or simply decide not to implement the rules at this time at all. So it's very much a wait and see, but as far as the next steps are, comments are in, and we're waiting to see those results and feedback. Next slide. So moving on to conditional payment recovery, this is just a general overview of what that looks like. I think it's pretty obvious that when we're talking about conditional payment recovery, it's applicable to claims involving a Medicare beneficiary. It's used to identify treatment administered and paid for by Medicare, where Medicare Secondary, such as to work comp, liability, and no fault, and Medicare is entitled to be reimbursed as a result. So Medicare Secondary, they make payment, it's conditioned upon being reimbursed at some later date. Next slide, please. So a couple changes, a couple issues with conditional payment recovery these days. If you're dealing with this, you probably have seen this. I think that the CRC grouper, or the Commercial Repayment Center's use of the grouper, has been one that has been a historic issue that has been raised. Basically, the grouper is the algorithm that is utilized to kind of identify and match claims that Medicare can recover on based off of the ICD codes that are reported through Section 111 or phone reporting. What's interesting is the grouper that the CRC utilizes is supposed to be the same as the BCRC grouper, but we, at least on our end, have seen a lot of differences where the BCRC is not including, or not as inclined to include, treatment that's not related to the claim. Often with the CRC grouper, we see things like sleep apnea, heart condition issues, diabetes, which are clearly not related to, like a lumbar comp claim or something of that sort, where it's clearly not related at all. But in a recent town hall, the CRC indicated that they were aware of this, that they are looking into it, and so far we haven't heard of any other steps being taken. But if that that gets taken care of, the recovery letters that are from the CRC should be much more accurate and should require less need for disputes. But right now, it's something that we continue to monitor. A couple other things, again, kind of moving clockwise, is the CRC's handling of unfavorable redeterminations. That's when you dispute a charge from the CRC, and in the past, the CRC was more willing to kind of work with you a couple of times, looking at evidence, kind of reviewing disputes, kind of working to come to terms with what's being argued, and reasonably looking at whether or not a dispute is valid. We've recently started to see that the CRC is starting to take a more kind of black and white look at things, and if they issue an unfavorable redetermination, that they're not willing to take a second look at it, and really kind of pushing debtors to appeal it to, or utilizing the formal appeals process and appealing it to a QIC or the qualified independent contractor or an administrative law judge, or down the line, Medicare Appeals Counsel or whatever. But once you get past the QIC, it can take a real long time to get your day in court or get in front of an ALJ. So at that time, debtors are kind of put between a hard place where interest is starting to accrue, and you have to kind of decide whether or not you want to make payment, or risk maybe a treasury offset or something of that sort. So it's been a little bit more of a restricted and a tricky handling process. And unfortunately, the disputes, when you couple that with things like the CRC grouper and the level of dispute that needs to be made, it can be a problematic situation. Talking about the open debt report, that was rolled out in October of 2019. This was where Medicare is allowing for a report of debts that are attributed to work comp and no-fault claims to be downloaded off the MSPRP. This was available for account managers of the account only, and was, in our opinion, is great, because being able to kind of getting in front of the debts that are out there, seeing where the debts are, it was a great tool for debtors to use. What we have noticed recently is that the open debt report might not be 100% accurate, so folks utilizing this just needs to kind of be aware of this. Initially, we saw a lot of situations where not all open debt was being reflected on it, and there needed to be some update that occurs to have that occur. But to the extent that you have cases on there, it's something that we would advocate, just kind of keeping in front of, making sure that they're being taken care of. And if there's anything that needs to be disputed, you should. If there's anything that needs to be resolved and paid, that should be taken care of as well. And then as far as debtor switching, that's a phenomenon we started to see that's especially problematic for work comp cases, where the parties come to an agreement, a settlement agreement, a conditional payment amount is being requested. It shows, for example, $0 is owed back to by the debtor. The parties settle with that in mind, and then after the claim settles, the CRC closes their case. The BCRC, the other contractor, for whatever reason, opens up a case and starts to pursue the beneficiary as the debtor in the settlement. And that's been problematic, because after the settlement, it's often difficult to kind of get back in touch, obtain the correct or the needed consent forms to correspond with the BCRC. And oftentimes the BCRC is looking at different dispute arguments that are valid than a carrier would otherwise be able to use. So that tends to be a problematic situation as well. So just, in summary, CRC is, still aggressively trying to recover, continue to review recovery charges for accuracy, and always, double check your Section 111 data when looking at disputes, because if it's not lining up, the contractors are less likely to accept a dispute that contradicts that data that's being reported. All right, let's take a look at the next slide. I mentioned the Treasury offset program. Just want to mention it here again. Basically what that is if a debt is not paid, if a conditional payment recovery debt is not paid, it's referred over to the U.S. Department of Treasury for recovery. Treasury has an opportunity to actually offset a return, federal return, or in some cases a state return, to recover those dollars. So something to keep an eye on. We started to see an uptick on this probably early to mid 2018, but this is certainly something that's been on the rise. And with the fact that the CRC is now pushing more cases to the QIC and the other appeals periods, that could also trigger more cases to go over to Treasury as well. So something to keep an eye on as an enforcement mechanism for the government. Next slide, please. And then finally, talking about Medicare Set Asides. Medicare Set Asides, just kind of in a nutshell, again, generally speaking, just a level set for everybody. Medicare Set Aside is a fund of money that is segregated out of a person's workers' compensation settlement, only to be used to pay for work comp related medical treatment after the settlement. And the reason for this was pretty simple, really, that in work comp cases, historically in the past, an individual might be awarded indemnity benefits, permanency benefits, as well as future medical benefits that was intended to compensate for anticipated future medical treatment. But what Medicare was seeing was that that amount of money that was designated for future medical was not necessarily being spent for future medical. And if the individual, the injured worker, was a Medicare beneficiary, they would instead submit those bills, even though they might be related to that injury and settlement, to Medicare for payment. So Medicare said, no, we consider that double dipping. We'd like to see some type of mechanism in place. And that's what the Medicare Set Aside was, to protect their interests. So it's a mechanism to consider future interest in a settlement and in a claim. And Medicare said failure to protect Medicare's interest and failure to utilize those funds attributed to future medical treatment for treatment related to the claim means that Medicare could deny payment if it was submitted to them. So let's say, for example, I injured my leg at work. I received $50,000 towards future medical to treat for that leg. If I don't set that aside, Medicare knows about this. They can deny any leg treatment that's submitted to them, and argue that I was paid as part of my work comp settlement for that already, and that should be spent first before Medicare steps in and makes payment. As part of this program, Medicare also can review certain proposals that meet the established review thresholds and provide certainty around those figures. So there's no question that that the amount is appropriate or reasonable. If Medicare reviews it, then the parties have certainty. They know it's as long as it's properly set aside and it's properly funded, then the parties know that Medicare should not be denying payment for treatment so long as that fund is properly exhausted. Okay, next slide, please. So with respect to work comp Medicare set asides, there were a couple things that happened recently that I'd like to highlight. First is the amended review eligibility period. So the amended review is something that Medicare introduced back in July of 2017 that allows parties to submit a re-review request utilizing new medical documentation to support a change in treatment. As part of that review criteria, Medicare imposed a 1 to 4 year window to allow for that to happen. So there needs to be a conditional approval within 1 to 4 years of the amended review eligibility. The amended review request. Medicare recently extended that in October of 2019. Now it's 1 to 6 years. So that's a great, change. My opinion is that Medicare should do away with it altogether, since the amended review only allows for one request for an amended review, and that would really allow for some of the older dog claims to settle, that have been kicking around for a while. But I'm not going to complain about an extension from 1 to 4 years to 1 to 6 years. So for those folks that have been utilizing amended review, I think that you guys are welcoming the extended time period. For those who haven't necessarily utilized amended review, I highly encourage it. If you've got those, a claim, an older claim with the Medicare set aside on file, that the treatment significantly changed, that if it was amended to be a lower amount in some way, then you might be able to find a way to settle the claim. Amended review is really set up for that type of claim. The other thing that's been kind of on our radar this year as well is that Medicare is requiring new language for the workers' compensation Medicare set aside submission consent form. So as of April 1st, 2020, Medicare is requiring this new language. And the main change is that Medicare is now requiring that the individual, the injured worker, certifies that they've approved of the contents of the submission before it goes to CMS. They need to initial that. So previously, there was no requirement to do this, and what that means is that a lot of times, as part of streamlining the submission process, parties might try to get that consent form signed as soon as possible, just to have it on file. So when the parties are ready to submit, they can just submit it. However, now it appears to be a condition precedent where there needs to be a submission in play before that occurs. So something to just kind of keep in mind. We're still monitoring that and kind of how Medicare's treating that, but just something to keep an eye open for. Something that continues to change and we continue to monitor is Medicare's pricing trends. I would say in 2019 we started to see Medicare start to include things like urine drug screens regularly, changes with how Medicare is pricing out surgeries, how Medicare is pricing out spinal cord stimulators and things of that sort. So unfortunately, as the Medicare set aside program continues to mature, Medicare continues to try to find ways of including more treatment. So I think it's really critical to make sure that you have a good cost mitigation program, that you're looking for ways to keep costs down in a Medicare set aside, and to make sure that the documentation within any type of submission to CMS is very, very clear. So with that, I'm going to turn it over to Shawn for the updates on the work comp administration process, which has also been new in this recent past year.
Thank you so very much, Sid. Appreciate it. It was excellent. So we're going to switch gears here, and Sid kind of ended it out on the Medicare set-aside portion. So this is going to go totally into the realm of post-settlement and what happens after the Medicare set-aside has been funded, the claim is settled, and potentially gone to CMS for review and approval. So what is professional administration? Well, it's simply the administration of MSA funds by an independent third-party company like Ametros, but there's so much there to with respect to what has to occur relative to compliance and administrative tasks and support there and coordination of care. So high-level requirements of professional administration. The first thing, as CMS outlines, has to be in a separate interest-bearing account. You can't commingle the funds with other monies that you have. The professional administrator will receive bills and ensure proper reimbursement per CMS's guidelines of how they outline things in the WCMSA reference guide and the self-admin toolkit, as well as handle the annual reporting and attestation to CMS, and of course coordinating care with various providers who transmit invoices to ensure that bills are getting paid and that they're getting paid properly, i.e. Medicare covered and connected to that underlying claim. So CMS highly recommends professional administration. Here's sort of their quote in the reference guide. It says, although beneficiaries may act as their own administrators, it's highly recommended that settlement recipients consider the use of a professional administrator for their funds. And it's really for good reason. So here's some of the benefits of professional administration. Extends the life of the fund of the MSA through savings, potential savings by leveraging medical network platforms. So we can realize savings to ensure that that MSA fund is extended as long as possible, so it pays for those injury-covered Medicare expenses. And they can occur through several spend categories, including RX and provider and hospital and durable medical equipment and home health care. And it's sort of, we talk about the MSA, you can have the perfect MSA that allocates down to the penny how much someone's going to need for their lifespan, but if the MSA is mismanaged or the funds are mishandled and that fund is depleted prematurely or it's not in compliance, then sort of all that effort that was done with that MSA is for naught, because there could potentially be a cost shift back to the Medicare Trust Fund. Also, secondarily, provide security to the settling parties that the fund's going to be spent in accordance with the guidelines. So if you're a payer or a claims administrator, or even a regulator, your judge that's approving one of these settlements, I mean, the thought is that, and the hope is that those funds are going to be spent in accordance with CMS's guidelines to avoid a cost shift. And critically, that includes the attestation component. The injured worker also has a resource in a professional administrator that they can turn to if they have questions with respect to the care that they're receiving or questions that they have in regards to their Medicare set-aside. And recently, we've seen quite a bit of increased activity in the last 6-7 months and engagement in the Centers for Medicare and Medicaid Services with respect to how guidelines around how professional administrators and administration of an MSA goes. And the first goes to electronic attestation. That's the electronic submission of information over to Medicare with respect to the spend of that MSA. But before you can get there, you kind of have to level set to explain to folks exactly what attestation is. It's information sent to Medicare, specifically the Benefits Coordination and Recovery Center. And some folks get kind of tripped up around that because as Sid outlined on that great slide that showed who the contractors were, he figured, gosh, well, those are the people who deal with conditional payments against beneficiaries, either post-settlement and work comp or in a liability claim, but they're actually the entity that receives these attestations annually within 30 days of the anniversary of the settlement. Additional attestation reports have to be provided if a lump sum or a structured account has permanently exhausted. And it's especially critical with annuitized MSAs because CMS, of course, is a large entity. It can make mistakes. So on that, and a little bit of a quick shout out to structured settlements, because the funding of the MSA and professional administration really sort of go together as a nice package. And as most folks know, an MSA can be funded either via lump sum, a one-time payment, or they can be structured or annuitized. And there's some big benefits there as far as lessening the cost on the initial funding of the MSA and extending the life of it. But it's critical that attestation occurs if in any annual period that fund exhausts. If it temporarily exhausts, then Medicare picks in and pays for the work-related items and services that are covered by Medicare. So in certain instances, if Medicare has the incorrect information and or attestation doesn't occur accurately, Medicare could potentially deny treatment. We've seen that occur in those instances. So while there's tons of benefits, it makes all the sense in the world to have an MSA structured with professional administration. It's critical that that attestation occurs. And what does it have to contain? So it's a signed statement over to the BCRC that outlines the total spend for medical services and prescription drugs, and the total amount of expenditures, as well as any interest that was gained on that account, and then the total balance at the end of the year. And then, of course, if there's any temporary exhaustion or permanent depletion in the interim, there has to be an additional attestation that occurs. Well, there's also record-keeping requirements that go along with this for each transaction, including the date, the amount paid, the check number, who the funds were made payable to, the date of service, et cetera. So the big news here is that in the October version 5.9 of the WCMSA reference guide, the WCMSAP, which is the portal guide, as well as updated information, the reference guide, they allowed for the submission of electronic attestation information by individuals or representatives and professional administrators. So what does that mean? That means that entities like Ametros now have the ability to send in bulk information in a file electronically to Medicare, so that they have much more accurate data as far as the data file layout goes. It looks much more something like akin to a Section 111 data file. And what this is going to do, the ability for us to report to Medicare electronically, is it'll improve the accuracy and allow us to correct discrepancies in real time. So the example was if an account happens to have a temporary depletion, if it's an annuitized MSA, we're able to report in real time to Medicare to ensure that they have that information versus either sending in a facsimile or transmitting something via the post. It allows us to also track and confirm when Medicare has obtained that information as well. And there's a note here too on sort of associating a case with the WCMSAP. A submitter now needs to note if it's going to be professionally administered. And I think initially there was some confusion around, do you need an entirely executed professional administration agreement? No, you don't. You can send in a draft agreement, or we've developed a single page form, that PDF that can be sent in that has Ametros' information and tax identification number, and address, et cetera, to associate the case. But once the case is associated with a professional administrator, they have the ability to then submit that electronic attestation information. Another big change too, frankly, probably the biggest, was that CMS changed guidelines for professional administrators around handling Medicare set asides or administering Medicare set asides when a frequently abused drug was included. And the quote here is that CMS highly recommends professional administration where a claimant is taking controlled substances that CMS determines are frequently abused drugs, according to CMS's Part D utilization review policy. And just as a note here, CMS has defined those drugs as benzodiazepines and opioids. And those are typically, especially opioids, are pain medications that are included oftentimes in a workers' compensation Medicare set aside. If there's a bodily injury claim that's included. And there was a lot of efforts that went into this behind the scenes as far as advocacy with CMS. As folks know, it sort of peaked in 2017, but we're still seeing it as sort of a national healthcare issue where there's either overutilization or misuse of prescription pain medications, especially in the class of opioids and those related drugs that have greatly affected the general population, specifically with regards to injured workers. So CMS expects that MSA funds are going to be competently administered in accordance with Medicare coverage guidelines. So with respect to Part D, drug utilization review, as well as developing or instituting drug management programs. So at Ametros, we've gone through, and we were doing a lot of this before, but we've sort of enhanced our already existing prescription drug handling policies and have oversight and constant review now of certain classifications of treatment that occur, certain frequencies and drug combinations, and specifically with utilization. If certain drugs are utilized at more than X amount of pharmacies, et cetera, that we will be able to take action and alert either pharmacies or prescribing physicians and our members too, the injured workers who are professionally administering this MSAs for to ensure their safety. And we commend CMS on these efforts because it sort of acts like an extension of the already existing Part D guidelines if the individual was treating with their Part D. And they're good sort of bumpers that improve quality of care and ensure safety. What else? So New York updates to hold harmless and settlement language. New York issued last month a bulletin that indicated it wouldn't approve any Section 32, which are lump sum settlements in New York that require a claimant to indemnify or hold a carrier harmless for the mismanagement of post-settlement Medicare Set Aside administration, or spend. So basically, in layman's terms, the carrier is saying, hey, if you claimant, if you mismanage your Medicare funds and there's some sort of exposure from CMS or otherwise, you're going to hold us harmless in case Medicare goes after us. And I get it. I understand why a payer would be concerned, because once the MSA is prepared and approved, and if it's going to be self-administered, it's up to a layperson who might not be that sophisticated with respect to all the requirements that goes into administering a Medicare Set Aside, and is sort of strapped with, as you saw in previous slides, with regard to record-keeping requirements and having to coordinate care and pay bills pursuant to CMS compliance rules. It's quite difficult. So the carrier is obviously concerned, and the language is utilized to as sort of belt and suspenders and protection. There's a few other jurisdictions who've sort of, I've seen anecdotally, go in this direction, but New York issued this rule, and I would say I would posit that professional administration is really the effective solution here versus having that provision. Not that it's a bad idea to ensure mitigating against that potential risk and exposure, but at the end of the day, what the parties are trying to accomplish is assurances, beyond assurances, the actual activities that go along with properly administering and managing funds. So, I guess long story short, if the parties are coming up on issues trying to resolve cases where they can't utilize these hold harmless and indemnification provisions, professional administration is a potential solution to come in there and assist. I think another one, and I'm not sure what Sid's seen around, including acupuncture now in allocating Medicare Set Asides, but this past January, CMS now allows for if there's chronic lower back pain, and there's certain guidelines that go around this, and it's limited in certain situations, but as an alternative to pain medication, specifically opioids, CMS decided that they were going to allow for coverage in certain instances of chronic lower back pain. And we've seen an uptick in this service with respect to our members who have been prescribed this, but otherwise before it wasn't covered by Medicare. So this is just an instance where Medicare is sort of moving in the direction to different holistic approaches as far as allowable covered treatment. And I guess to that end too, even with sort of the COVID-19 time, we've seen Medicare have additional rules around telehealth and telemedicine services as far as delivery mechanisms to to deliver care to individuals. So that was sort of the professional administration update. I wanted to make sure I left at least 5 minutes to answer some questions, and there'll likely be more. We have a ton that came through the chat box, and I was scanning them. Most of them are for my colleague Sydney Wong here, so I'm going to pitch it to you and just scanning here. So one attendee asks, can you clear up the difference between a request for review versus an amended review? Are they the same thing or are they different?
Yeah, it's a great question. So when you submit an MSA to CMS for review and approval, and I don't know necessarily if you mean, that initial review, Medicare, will, and assuming Medicare provides back a decision, a determination, either approving it or adjusting that number, then you have an opportunity to ask for what they call a re-review. And that's, and an amended review is a type of re-review, but it is more restrictive. Well, I don't even know if it's more restrictive, but it has more restrictions around, what type of claim qualifies for that. So I guess to your question, it is different. The amended review requires a determination initially, and then you can then utilize new medical records to adjust that prior decision, which is something that Medicare didn't have in place before.
Well, thanks, Sid. I can take this next one here. It says, with COVID-19 pandemic, has Medicare loosened restrictions on what can be paid for from an MSA account / fund? So we've actually gotten some questions from our membership, and they'd been inquiring about whether or not they could utilize funds in a different fashion. And obviously we went to CMS for confirmation, and the short answer is no. There hasn't been any change with respect to the core tenet that it's injury related treatment that's otherwise covered by Medicare. So, if it happens to be something where the delivery service can be through telehealth and CMS allows for it, that's fine. But there's, you can't unfortunately utilize the funds to pay for non-injury related care specifically that's not covered by Medicare.
Yeah, one thing would be interesting to kind of just monitor. Yeah, Shawn, I was just thinking one thing that would be interesting to monitor, especially for individuals that are first responders, is whether or not COMP is going to consider covering for COVID-19 related injuries, and if so, whether or not that's going to show up in a Medicare set aside at some later date, and then as a result, then maybe the set aside could be utilized to pay for that type of treatment. But I don't think we're there yet. But it would depend on the coverage of that quote unquote injury as it pertains to employment.
Exactly. Thanks. This one's going to be, I'm going to pitch it to you, Sid. So the attendee asks, how long does a change in the pattern of treatment need to last in order for CMS to consider excluding it? I'm not sure. Does that make sense?
It does. So Medicare doesn't require a long period. I mean, they would just need to show a recommendation for it and the fact that it had changed. So if it's a medication, we typically say 1 month should be sufficient as long as it's supported by the medical records and the pay history. So it doesn't take a long time. It just needs to have the supporting documentation.
Gotcha. Seeing here, someone asked if Medicare, I lost it in the chat box, but someone asked if Medicare pays for treatment outside of the United States, and I have this vague memory of years ago, you and I working on some research project on this.
Yeah.
You might not remember the rules, but I
do remember it.
It's fairly limited. Go for it.
Yeah, so it's highly limited. It would be a situation almost like a Defense-Based Act type of situation. It would be if the closest, I think it was if it was overseas, but I think it has to be the
proximity to a provider Yeah, and there was
Exactly.
even a cruise ship
Cruise ship situation. Yep.
instance. But anyways,
Yeah.
it's a good
Highly
question.
limited though. Yeah, it's highly limited.
It's highly limited. Exactly. Here's one. I'm settling a case and have a client who wants to know if they can pay for their Medicare co-payments out of the MSA after the settlement. I can feel that one. I guess the short answer is no. It's fairly clear that those the co-payments and even deductibles are delineated to be excluded outside in the WCMSA reference guide and the self-administration toolkit. I think, let's see, we're coming up on time, and I have one more, Sid. I'm going to give you any trends you're seeing with recent CMS approvals and any new changes to Medicare, including certain drugs or treatments that haven't historically been included, like we saw with Lyrica.
I would say Lyrica, you brought up the acupuncture, right? Because there was a change in Medicare coverage. But as far as treatment that's kind of snuck in that traditionally was excluded, I haven't seen any trends on that part. Nothing outside of what we primarily discussed. I would, continue to, watch the frequency of treatment to see if they start to tick up. But no, I haven't seen anything that's notable right now outside of what I already discussed. Yeah.
Thanks, Sid. No, with that, we're right on 3, so I think we're going to go ahead and wrap it up. There were quite a few more questions. We'll be sure. I'll make sure that Sid, majority for Sid, to make sure he gets those. I want to give a special thanks to Sid Wong at ISO for presenting today. Really appreciate it, Sid, and thanks to all the attendees who've joined. I hope you all remain healthy and well. Appreciate
you
it
as well.
very much.
Always a pleasure. Thanks, Shawn. Thanks, everyone. Have a great day.
Take care, everybody. Bye now.